Let's have a seat, guys. Let's start. We are already late. Welcome, welcome, welcome. Let's have a seat. Let's come in front. Come in front. There is these front seats. Let's come and fill up these front seats, guys. It's a live show, so I'm very excited. Hello, people online. How are you? I'm saying people online. Oh, you're live.
Hello, how are you? We were well on mute. How are you this morning?
We're good. Thank you for joining.
You're welcome.
Do we have young people in the room? Where are the young people? Do we have young people in the room? Do we have someone who feels young in the room? I love that energy. Do we have young people in the room? Let me hand over to the facilitator of the session. I'm not the facilitator. Oh.
Okay, thank you, Grace. Let's get settled. Let's get settled. So we are starting now. Yeah, if we can feel. Okay, great. Then, are you still going to close that? No need. Okay. Okay, good, cool. All right. My name is Tabang Masangane from Swatini. I'm the PATA representative, country representative. So we are welcome to Africa Cafe 4. We know that this cafe session is the live stream. So we will request that we fully participate, listen to our presenters, ask questions, and I hope more people will be joining. Okay, thank you and welcome everyone. Welcome our online presenters. So online we have Dr. Apilito from Mozambique. We have Edna Masiwa from Zimbabwe. And we have Dr. Christina Lorenz from South Africa. All right. So, and we have our panelists. I'll introduce each and everyone, each of them later, but we have Grace, today we swap. Good. Okay, so we have Grace Gulupe from who is a YAP member. We have Pumlile Gina, a head nurse, healthcare provider from Eswatini. And we have Immaculate Oliku from Kenya, looking into issues of policies. Okay, so let's get started. So you know that under the Global Alliance, we have three main pillars or strategies that address our goal of ending HIV in 2030. So among the three pillars, we have, among the four pillars, we have pillar 4, which talks about addressing rights, gender equality, and social barriers that hinders access to HIV services. So we know that this is very crucial in terms of addressing or responding to HIV because it directly addresses issues that influence individual access to HIV prevention, to treatment, and also to support services. So we know that it is also very crucial to address these issues because by addressing them, we'll be able to reduce the stigma and also the discrimination which is being faced by our service users. And also it is helping us to improve our health outcomes for women and our girls. And it is very crucial in breaking down the social and legal issues that also provide barriers in accessing services. And this is also very important in promoting human rights. So we will be taken through our three presentations on how can we best address these barriers or respond to these barriers. So we have, like I've said, we have three speakers online, and they'll be able to respond to whatsoever question we have. So let me just introduce the first speaker so that we go without any waste of time. So online we have Dr. Christina Lorenz, who is a senior researcher at the Institute for Life Course Health Research at the Stellenbosch University here in South Africa, and an early career researcher at the Accelerate Hub at the University of Cape Town. So her work focuses on building evidence for interventions in areas including adolescent, mental health, resilience, and well-being for young people. So today she will be addressing issues on or topics on building a supportive ecosystems for accessing and retention for HIV and AIDS. So HIV care. So also she'll be talking about addressing the barriers and also enablers to accessing and staying in care. So that is a very, very crucial and important topic. And she will be also talking about the social ecological models, which can help us to focus on the quality care and also addressing these issues at different levels. That is at the individual's level, family level, household level, and also at the community and health systems level. So without any waste of time, let us welcome by the clap of hands, Dr. Christina Lorenz. Thank you.
Hi everyone, welcome. My name is Christina Lorenzi and I'm here today to present on building a supportive ecosystem for access to and retention in HIV care for adolescents. So I wanted to start by just presenting a few barriers and enablers to accessing and staying in care that adolescents are considering and that we're considering as people who study, work with, and support adolescents and young people. So the period of adolescence is one of transition. There's multiple psychological, social, and biological changes that are all happening at the same time. And those sit kind of at the foundation of the experience of adolescence. But for adolescents who are living with HIV, who are living in high HIV burden areas, who may have to kind of think about HIV in navigating sexual and romantic relationships, even if they aren't themselves living with HIV, these types of changes are happening at the same time that they need to be thinking about the need for routine engagement in HIV testing and or care. And what I wanted to do in this presentation is to share some key insights and reflections on what we know and what we're learning about the factors that shape the access to and retention in care for adolescents, and specifically in their ecosystem. So in the places where adolescents live and work and go to school, and in the interpersonal relationships that they have in their day-to-day lives, and really think about how some of these factors play out at each of these levels. I think what I'll try to do as well is talk about some of the challenges, but then also some of the strategies and solutions that are out there that can be helpful for thinking about how to better respond to the diverse needs of adolescents living with and affected by HIV. So I think this is a very common way to understand multiple forces at play with the socio-ecological model. And I think these types of models, they've been adapted over many years, but they can help us to really imagine the different stages and levels at which these different competing forces or factors might be playing out. So today I'm going to be focusing across 5 levels. I'll start with the individual level, moving on to a family household level, deliver some considerations around the school and community level, the health system level, and finally the kind of policy or societal level, the biggest level at which factors might be shaping adolescents' experiences. So thinking about the individual level for adolescents living with HIV or affected by HIV, what drives their ability to access care and to stay retained in care? I think there's a lot of emerging evidence around the role of stigma, self-esteem, and also broader factors related to mental health and well-being, as well as resilience, which is kind of an individual's ability to bounce back, to navigate their way to resources. All of these things can shape the way that you engage in care and seek care. So it might shape the motivation that you have to seek care as a young person. It might shape how comfortable you feel with going for an HIV test, or even initiating a conversation with a healthcare worker to say, I'd like to have an HIV test, or I'm thinking about having sex with my boyfriend. What is that going to look like for me? So a lot of these conversations, really depend on the individual level, how adolescents see themselves and how they feel comfortable to engage. There's also challenges in their day-to-day lives. So potentially some of these things might be barriers to pill taking. We've heard a lot about mental health and adherence and the link between depression, and what that can do for young people's motivation or ability to feel compelled to adhere to their treatment over months and years. And we're also learning a little bit more about the role of stigma and different types of stigma. So we often think about stigma as something that you're feeling from other people, but there's a lot more that we're learning about the role of internalized stigma, which is stigma that you might feel towards yourself, shame, self-blame, self-doubt. And we're doing some analyses for a project called the Masana Young Moms Project, which is looking at a cohort of adolescent mothers living with HIV in South Africa, and finding through some emerging quantitative data analysis that at younger age at first birth, so moms who have their first child before the age of 18, and those who have higher levels of internalized stigma are associated with much poorer levels of adherence to ART. So these are some important considerations and also really help us to understand the emerging need for stigma reduction interventions and specific approaches that can support internal capacity, resilience, and confidence for youth. At a family or household level, there's also a number of important considerations because adolescents mostly are living with caregivers and family, up until they leave school in a lot of societies. So the ability and the availability of parents to be available for their kids, as well as the kind of psychosocial support that they can provide, those things can actually buffer against and help against some of the negative effects of this internalized stigma. But there's also other things that are going on at the household level. So there might be considerations around caregivers' own mental health and well-being. Often, adolescents who are growing up living with HIV also have a parent or caregiver who's also navigating that journey. And so disclosure can be a really difficult but important kind of factor that shapes engagement in care. So disclosure by parents and caregivers to their children about their own HIV status, as well as by adolescents to their family members, can really help reduce barriers to care, can help make it easier to have conversations about going to clinic, getting care, staying retained in care, talking about challenges to adherence. At the same time, it might be difficult to have these conversations. We know of lots of cases where these conversations are not fluid, they're not easy, and really thinking about what shapes the kind of intergenerational dynamics is something that we need to think a little bit more about when thinking about how to support caregivers and families with adolescents to ensure that they're getting access to and staying retained in high quality care. Importantly, resources within the household might also shape the ways that families and individuals are able to engage in care, especially in settings where people are experiencing high levels of adversity, poverty, where you're living in rural communities that are far from clinics. So there's a lot of considerations at this family household level that might make it difficult to access care. The photo on the left of the VUCA intervention comics, you can see on the bottom, show that, this is an example of intergenerational, parent-child or caregiver-child intervention that really aimed to engage parents and their children together to talk about some of these difficulties around HIV care and retention. But there's a lot more work to be done to expand these types of interventions and improve communication between caregivers and adolescents at that really kind of difficult transitional period. I also wanted to speak about the school and community level. So schools are where the majority of adolescents are spending their time, most of their time. And so we really need to think about using these opportunities and really leveraging schools and education spaces to improve healthcare. Sometimes this happens and sometimes it doesn't. I think there's lots of examples coming out of the space, again, in South Africa, where there might be parent, school governing boards, parents who are involved who say, I don't want a mobile clinic coming to my child's school to test for HIV or to test for pregnancy or to give an injection because that's against my values. So there's a lot of kind of conflicts at that level as well, even when trying to expand and engage. I think, we're really trying to think about how do we navigate this space and really ensure that we can promote health for adolescents, especially adolescents living with HIV, at the same time that we're, aware of the complexities of some of these environments. So one of the things that we've been doing through the Masana Young Moms Project is really trying to engage the different people within this ecosystem of, the young mom. So teachers, parents, caregivers, community leaders, NGOs, even religious leaders as well. So really thinking again, who are the people who are involved, who might have some ability to shape the conversation, to help support better policies that can smooth the barriers to accessing care. And I also wanted to highlight a great program that I've recently learned about called the Red Carpet Program, which is an initiative by ViiV and the Elizabeth Glaser Pediatric AIDS Foundation that's been working specifically in boarding school environments. I think initially in Kenya, but their model is available and accessible to people in other countries as well. And really trying to think about the different nodes of support that adolescents who are living with HIV, who are in boarding schools, can access to make sure that they can continue with viral load testing, can continue to receive support, counseling and mentorship as well, and then also have, the kind of more tangible needs of accessing a timely ART supply. So this is something that I think, more and more people are thinking about, thinking around the school level. And then at the health system level, I think, these are things that we've been talking about and hearing about for a long time, but I think they continue to remain important. Having accessible and adolescent responsive, sometimes we call it adolescent friendly health services, is really critical to supporting their engagement in care. Some of the data that I'm showing here is from the Hey Baby study, which is a cohort of 1,000 young moms. And actually, I believe this is also for a broader cohort of young women living with HIV as well. And thinking around where the role of health facilities come in, having safe and affordable facilities that are able to be accessed without too much of a challenge for adolescents, but also having kind and respectful staff who don't shame or demean adolescents who are maybe missing a prior appointment. These are really, basic but critical building blocks to improving multiple HIV outcomes for adolescent girls and young women who are living with HIV. And we can see that across these different 5 outcomes shared here, each of them are really bolstered by having both accessible clinics and adolescent responsive healthcare. And I'm just going to move on to think a little bit at this bigger level now. I think we've talked through a lot of these kind of different more community-based levels. But at the societal level, it's really important to have enabling policies and environments that can support adolescents transition to adulthood, that can support them to feel like they can thrive and they can seek the kind of lives that they want to lead. And one of those basic building blocks is really ensuring safety from gender-based violence, discrimination, and forced disclosure. There's also a number of countries where HIV is still criminalized. And so really trying to think about what are the barriers that exist. You know, often it's around criminalization of HIV status, and some of these are really persistent barriers to accessing and feeling comfortable to access HIV care. Similarly, there's been a big push, especially by UNICEF in East and Southern Africa, to think about age of consent laws. So thinking about harmonizing laws for sexual activity, marriage, HIV testing, and initiation and care in places where these laws are different and where there's different criteria for young moms or young people who want to go and get an HIV test. You know, these things can be really challenging. It can provide really stringent barriers to care. So, for example, in South Africa, if you're 12 years old, you can say, I want to go get an HIV test. You don't need parental consent. In other countries, you need to be 18. And sometimes, you know, we found that there's instances where young women are married at an earlier age than they can actually access an HIV test. So these are all considerations that can really provide or present significant barriers to accessing timely and necessary care. And lastly, I think in a broader conversation around adolescents' autonomy and their evolving capacity to make their own health decisions, there's a great resource by the World Health Organization that focuses on assessing and supporting adolescents' capacity for autonomous decision-making in healthcare settings, which I would recommend taking a look at. It's very clear and it really spells out some of the key considerations for focusing on where adolescents are on their developmental journeys and thinking about supporting them as they transition to adulthood to be able to have dynamic and well-considered conversations about their own health and well-being. So I'll close with some gaps in future directions. I think from the work so far that I've presented and some of the work that we'll hear about across the summit, you know, more adolescent-driven solutions are needed. So peer support is a big building block, but also adolescent advisory committees and research. I'm a researcher, so that's my space that I'm in. Research that really involves and engages young people along the whole project continuum. I think it's really crucial to start bringing these voices in a very deliberate way. Increasing the ability of adolescents to kind of engage with different people as well across sectors, across generations, and also not only adolescents, but individuals working in healthcare spaces and education spaces. We found through some of the work that we've done that this intergenerational dialogue and exchange was really critical to kind of bridging perspectives and ensuring that you can cross some of these divides that exist. And I think when it comes to barriers in care, this is a key consideration. I think one thing I wanted to also just end on is to reflect that stigma and discrimination remain persistent roadblocks for care, especially for adolescents. And so we need to really start to think about prioritizing approaches and doing so in a systematic way to break down stigma and discrimination, to ensure that adolescents can access and then stay retained and engaged in care, which is really important for their future well-being as they grow. Thank you so much. It was great to be here with all of you today, and I look forward to a discussion later.
Wow. Okay, let's put hands for Dr. Christina. Thank you, Dr. Christina, for that insightful presentation, especially that you are touching on the different levels. So we have all identified some areas where we could maximize our efforts to address these barriers. And it is not enough to address it at one level. So we've realized that we need to address it at different levels, from individuals level up to a societal level. And we appreciate that she's touched on issues of involving our adolescent in adolescent-driven solutions. I think this morning we were able to, actually we have the privilege of listening to one of our young people here in the earlier presentations, and she he talks or she talks about exactly involving them in terms of making those platforms where young people could be involved, even in the policy making platforms. So we are happy, and let's just document our questions. We'll have time to reflect and also to ask questions from Dr. Christina. So we are moving forward with our presentation 2. So we have Edna Masiwa from Zimbabwe. Edna is executive director of the Women Action Group. He has designed, developed, and managed complex programs on GBV, gender-based violence, and SRH issues. So she has been able to engage traditional leadership and the communities on harmful and cultural practices. So Ms. Edna is going to be presenting on community-based dialogue platforms for gender equality. She'll also present some snapshot of statistics from the gender-based violence in Zimbabwe and how they have addressed such issues at all levels. So she will also share experiences, her vast experiences in a model, what we call a peace hub model. So this is a very critical model. It provides a safe space for communities to address gender-based violence. So let us welcome Edna Masiwa by a clap of hands. Thank you.
It is my pleasure to be part of this PATA 2024 summit. My presentation is entitled Community-Based Dialogues Platform for Gender Equality. My name is Edna Masiwa, the Executive Director for the Women's Action Group in Zimbabwe. Basically, I'm going to speak of a model which we coined in Zimbabwe called the Peace Hut model. Starting off with the background of gender-based violence in Zimbabwe, 40% of women 15 to 49 years have experienced physical or sexual violence by an intimate partner. We also have noted that an estimated 16.2% of women 20 to 24 years are getting into marriage before they reach the age 18. The proportion of child marriage is higher it is at 22.7% in rural areas as compared to 7.2% in urban areas. And what we notice is various factors are attributed to child marriages. And these include poverty, low level of education, religious practices, as well as cultural and traditional beliefs that also encourage early marriages. So the result of these early marriages is the lack of self-efficacy in negotiating for safe sex and speaking about GBV among the most marginalized groups in rural areas due to information deficits, reduced self-esteem, and exposure to entrenched stigma and discrimination from society that compounds their exposure to gender-based violence. So this is the situation in Zimbabwe, and we then, as an organization, implemented the Peace Hut model. Peace Huts are safe spaces for communities to address GBV, gender-based violence. These spaces can be physical structures or any space that is accessible and safe for everyone in the community. It can be even under a tree. Peace Huts are required to have committee members for smooth operations. We expect about 6 to 8 members in the community, and Peace Huts have been found to be a powerful tool for inclusion and representation of leadership and gender equality. Moving on to what makes the Peace Hut unique. Peace Huts are they are powerful platforms for inclusion and representation. For example, women can be part of the Peace Huts. Young people can also be part of the Peace Huts, as well as persons with disability. So there's that concept of leaving no one behind. Everyone is part of the Peace Huts. And we've also noticed that cases are resolved at the Peace Huts at no cost. Peace Huts also work closely with service providers who have diverse expertise. For example, those from the Ministry of Health, the Victim-Friendly Unit of the Police, and the Ministry of Education. Moving on to achievement. These Peace Huts are very important because they were able to increase awareness on gender-based violence. Communities now know where to report gender-based violence. They are also important for resolving community conflicts and gender-based violence cases. And we also noted that through the Peace Huts, we were able to refer gender-based violence cases to other stakeholders. For example, the case care workers in one of the districts called Mutasa testified that Peace Huts are now making my work easy as I'm getting more referrals. So it really has contributed to referrals and effective response to issues of gender-based. We also note that Peace Huts are also playing an important role in linking up young girls who drop out of school with other NGOs and government ministries who can assist them with payment of school fees. And we further note that Peace Huts are encouraging women to venture into economic empowerment projects such as gardening, chicken rearing, and goat rearing through the internal savings and lending scheme that Peace Huts have also initiated at community level. To further highlight the achievements that came out of the case study of the Peace Hut model in Mutasa district, I will highlight two case studies. One was that for Chipo, not a real name, who was 14 years old and had eloped with a 27-year-old man while she was still in Form 1 at one of the schools in the province. Chipo's mother was part of the Peace Hut committee, and she brought her case to the committee, and the committee helped her to track her daughter, whom they found, and when they found Chipo's daughter, they took her in for counseling, and they supported her all the way. As they were talking to her, they also highlighted the issue of getting an HIV test since Chipo had sexual intercourse with the men she was living with. She went for the HIV test, which fortunately tested negative. And as we speak, Chipo is back in school and performing exceptionally well and achieving high grades. The second case study is about Sekai, and it's also not a real name, and her husband, who often argued because the husband had multiple girlfriends, which led to financial strain in their household. Much of the husband's earnings were spent on alcohol and his relationships, leaving them unable to afford their children's school fees. Sekai sought help from the Peace Hut in Mutasa district. And the Peace Hut committee assigned 2 members, as one male and another one female, to mediate between Sekai and her husband. Over the course of 4 dialogue sessions, the couple was able to work through their issues, and they were also advised to go for an HIV test. As we speak today, they are living peacefully and are financially stable enough to send their children to school. From the implementation of the Peace Hut, I would like to share the lessons learned from this model. We learned that the Peace Hut is a strategy that promotes movement building, which is key in ensuring that everyone plays their role in preventing gender-based violence. So in these selected districts, we now have a movement of community members who are standing up against gender-based violence. Peace Hut are also key in linking up with different stakeholders who have diverse expertise. Through the Peace Hut, we've been able to refer survivors of violence for psychosocial support. We also have been able to bring young girls back to school through what we have called the Back to School campaign for the young girls. The Peace Hut is also a strategy that promotes project sustainability. Even if the project comes to an end, the Peace Hut will continue addressing gender-based violence issues. I can confidently speak to that because we have stopped active programming in those 3 districts, but still we continue to get reports of what is being done through the Peace Hut in the districts. That is the end of my presentation. Thank you.
Oh, well, thank you so much, Edna Masiwa. We appreciate those remarkable achievements which have been done in terms of creating the awareness and also addressing issues of gender-based violence. So we know that by doing this, we'll be promoting the retention even to care. So thank you so much. Let us also document questions to forward to Masiwa. Then we have our last presenter or presentation. This one will come from Dr. Abilito, who is also online. Dr. Abilito is a medical doctor and a project manager at Moeti, Mozambique, leading the Pesingata project. He has extensive experience in both clinical and community pediatric HIV. So with over 20 years of experience in HIV, TB, and also SRH issues, Dr. Abilito now focuses on supporting communities to demand quality health services, including all the SRH and HIV services through community-based monitoring. So today he'll be presenting or sharing experiences from the Moeti project, which is empowering community through community-led monitoring. So he'll be addressing issues of the barriers and also increasing the coverage on art. And then he'll also talk about his experiences in the implementing a scorecard and also using the findings or results from the scorecard to improve the service delivery. So we like the fact that we'll be also presenting this at different levels of advocacy. So let us welcome Dr. Abilito by the clap of hands. Thank you.
Thank you for having me. I am Abilito Pintainho. I'm a medical doctor and I work for Moeti. So today I will be sharing an experience on empowering community through community-led monitoring. a work that was done in Mozambique, Inhambane. So several barriers existing to increasing ART coverage, adherence, and retention in care, such as long waiting times to consultation at the health facilities, recurrent stockouts on ART, lack of privacy and confidentiality, and low awareness of the rights of people living with HIV among the frontline service providers. To address these barriers, NUET implements community-led monitoring to enable local communities, particularly people living with HIV, to engage with frontline healthcare providers to implement with the aim to improve the quality of health services. Before, NUET used to use scorecards as the tool to implement community-led monitoring, which are the examples that I'm going to show today. But now, all the organizations in Mozambique, the organizations that implement community-led monitoring, are migrating for the new methodology, which is a survey, so that there is an harmony on the data and also methodology on community-led monitoring in the country. So this migration is being supported by a network of civil society organizations which receive technical support from NUET and financial support from USAID and the Global Fund and other national stakeholders. For NUET, community-led monitoring has three main objectives. One being monitoring the quality of health services. The second one is the identification and definition of health priorities from service users and service providers' perspective for subsequent integration in the health facility and district plans. And the other one, which is the last but not least, to build a body of evidence to define advocacy actions on public policies in the health sector. So the community used to say to the authorities, like, we have this and that problem at the health facility, for example, but the authorities used to say that they do not have evidence to use them to start on addressing those issues that were raised by the communities. So the community-led monitoring allows the community to have this evidence so that they can advocate for themselves. To implement the community-led monitoring, the first step is to train the facility level co-management and humanization committee, which is a group of people from the community along with the service providers, so that they know all the process that they are going to go through to have the community-led cycle of success. On the right, you can see the circle here, which are the steps to implement the community-led monitoring using the scorecard method. So we have the first step, which is mobilization. In the mobilization, we create groups, which are different groups in the community and also a group of health providers, so that these groups are the ones who are going to score on the next step, of course, who are going to score the predefined indicators. They are going to score like good, bad, very good, and very bad. So the third step is the systematization. After all the groups score separately, we have to bring together the results of the scoring so that we have, like, for one indicator, what was scored by all the groups in that pillar. And then we have legitimization of the single community matrix. What happens here is that after the systematization, we bring back the matrix so that the community can ensure that all the things that are in the matrix are definitely, or of course, the things that they discussed. After legitimization, we have interface preparation, where some people from the different groups who are chosen randomly. They are trained on how can they defend the ideas that they build on the groups, because the next phase is where we put the people who were trained in the interface preparation face to face with the health providers to the interface, so that they discuss and agree on the priorities for that health facility. And from those agreed priorities, they are going to design an action plan, which is actually the thing that will be followed through all the community-led cycles. So the cycle may take 3 months, 6 months, or some more time, depending on the objectives that we intend to achieve. So each month, this group comes together and discuss among the action plan. So they see whether the priorities were realized, are in process to be realized, or were not realized or resolved. So the ones that were not resolved are taken and discussed again to see what are the constraints, what are the ones that were not resolved are taken to the table and discussed upon to see what are the obstacles for them to be resolved. And if there is any kind of advocacy that needs to be done, so the advocacy will start from there. So after we finish, we will end up with the cycle. A report is prepared so that we have the results of the cycles to give back to the authorities, which is the process called devolution. So if we have things that were not solved and are above the capacities of the local authorities to solve, those things are things that are going to be taken into advocacy process. So the advocacy can be done at the local level, like community and health facility level, district level, provincial level, and sometimes national level. So after the systematization, we'll have a graph like this, and we can see here there is very good, very bad, and bad. So where there are high percentage of very bad and bad, those are the areas that we want to focus and put on an action plan. For example, on the last block of 3 pillars here, you can see that, for example, Jangamo district, there is only 2% of bad and 0% of very bad. But in Masinga district, you can see that bad and very bad, they both correspond about 24%. So in those health facilities in that district, we are going to include the IGN issue on their action plan, because it's an issue for Masinga, but it's not an issue for Jangamo. So this is an example of action plan monitoring. So you can see here that there are things that have been resolved, things that are still in progress, and things that were not solved. So we want to focus on the things that were not solved and discuss upon those in order to, if needed, we start advocating for those things. So what we learned on the community-led monitoring, the engagement of the health authorities, health facility representatives, community leaders, and other groups from the community enables and facilitates greater mobilization and participation of target groups in the community-led monitoring cycle. Because if we don't have the mobilization and the participation, we won't have the cycle. So the cycle, the community-led monitoring brings the community and the health facility staff closer together. allowing users and providers to know the challenges from each other. What's happened is that, for example, one barrier was that community was seeing that, okay, it's taking too long for us to be seen at the consultation room while the providers are still in the health facility. But what they didn't understand is that the health providers add another activities, like, for example, administrative activities, which require them to be doing all those activities in order to make sure that the health facility continues to function well. So bringing them together make they understand this issue. So it's good to bring the community and health providers together. The service providers recognize that improving quality of service depends on honest discussion on identification. Another lesson learned is that good results in some dimensions depend on collaboration between community and health facilities, and also the involvement of local economic actors as a support, under their social responsibility actions. So we saw it in some places. There were some health facilities that the health providers were always late because they didn't have where to live there in the area, because the health facility that didn't have a house for the health providers. So the community, with the support of local economic actors, they built a house for the health providers using local material. And also we have seen a health facility that didn't have a waiting house for pregnant women. So they were facing the problem of women giving birth outside the health facility. So the community, with the support of local economic actors, they built a house using local material. Now the pregnant women, they go to the health facility while it's closer to their due date, so that they have their births at the health facility. So it's important to share the evidence from the community-led monitoring with the stakeholders to inform planning process, joint follow-up, and advocacy. Another lesson learned is that we observed that interaction is better in groups where the discussion occurs outside the health facility, like the community members and the health providers. They feel more comfortable to have these discussions outside the health facility settings. So we observed that they, for example, started using their notebooks or simple A4 paper to write down, to systematize, and also to design action plans. So it was very interesting to see the community owning the process, taking ownership of this process. So observing the community engaged on creating, like, on action plans on paper, we saw that there is no need to have all these giant papers and stuff. We can use the local resources, like simple notebooks, to systematize and to design the action plans within the community. So this way, it will not cost a lot, and it will make community-led monitoring very sustainable. So these are additional resources on community-led monitoring activities. So you can go there, visit, and see all the work that we are doing upon this issue, this topic. Thank you.
Wow, thank you. Okay. Thank you so much, Dr. Abilito. That was a mouthful presentation. We also appreciate from your presentation the use of data to inform our plans, to inform our interventions. So data is very much important. I think in all the three presentations, we've picked that no one should be left behind. So everyone needs to be taken on board in terms of addressing all these issues. So we know that we are talking about addressing all the rights, the gender issues, inequality, and also the social issues. So thank you so much for all our presenters for the presentations that we've listened to, and we appreciate. So now it's time for our reflection. Let me introduce my co-chair, Margaret from Kenya. She's also the country representative. But before she takes the question and answers, can I introduce to you our panelists? So we have 3 panelists, different cadres, which we appreciate. And then we have Grace Ngulube. Grace, yeah, a young person. Okay, Grace is part from Malawi, a community healthcare worker, a founder of the Youth Health Connect 360. She serves as a member of the Global Fund Youth Council. She's also she also works as one of the Her Voice Fund ambassador for Malawi. She is a dedicated advocate for SRH. Grace is a peer supporter and a trainer in SRH and social worker, and she's a social worker by profession. She is also committed to empowering youth in health and rights, using her platforms to promote impactful change in her community and beyond. So let's clap hands for Grace. And number 2, we have Immaculate Oliku from Kenya, Enaya. So she is a senior programs manager at Network for Adolescent and Young People of Africa. She is a responsible officer for managing different programs within the organization. She is motivated to be an advocate for the voiceless and vulnerable girls and boys in the community through working with policymakers to provide the required services. Immaculate graduated with a master's degree in social development and has vast experience in SRH policy and legal environment. So let's clap hands for her. And last but not least, we have Phumlile Gina. Phumlile Gina is from Eswatini. So she's a head nurse at a Red Cross clinic, Silele Clinic. She's a dedicated leader, and she's implementing and also has implemented a lot of projects that aims to support orphans and vulnerable children, HIV and HIV at Silele Clinic. Currently, she continues to lead initiatives that promote awareness and support for vulnerable populations. She's implemented even advocacy initiatives, and one of those advocacy activities is stopping the stigma and discrimination among the young people and adolescents. So let's also clap hands for Phumlile. So thank you so much. We welcome our co-chair to facilitate the question and answers.
Thank you very much, Tabang. My name is Margaret Mbugua. I work for PATA based in Kenya. So I know the models were thought-provoking, they were interesting, and I know you have some burning questions. So this is your chance for Q&A. We'll go for 6 set of questions. So 3 from the men, 3 from the ladies, so that this is gender equality. The part of the session is on gender equality. So we'll take from 3 gentlemen and 3 ladies, and then we see what perspectives are coming through. Thank you. So maybe, the first question.
Good afternoon. My name is Notando Matsebula from Eswatini. My question is to Edna. Do you come across women who withdraw cases and are they victimized? And how do you deal with those issues?
Thank you, thank you. As you ask your question, remember your name, what you do, and the country, and who your question is directed to. So maybe next for the let's go to the lady, then the gentleman.
Bem, obrigada. Meu nome é Leonora Isabel Pindale, venho de Angola. E a minha pergunta vai dirigida mesmo à doutora Edna. Trouxe aqui uma situação que o Zimbábue vive, que é no quesito do casamento infantil. Sendo que as mulheres, na verdade, vêm sendo as maiores vítimas. Então, gostava de saber que estratégia que o país, né, com o governo e as entidades de saúde, tem traçado para responder de forma a proteger essas crianças e mulheres. Obrigada.
Thank you very much. Obrigado. Is it the way it's supposed to be pronounced? But thank you so much. I think we take another 3 questions from this side. Oh, the gentleman. Yes. Sorry for that.
Yeah, thanks for giving me this opportunity. My name is Cedric Nukeri. I work for Grassroots Soccer here in South Africa. So my question is based, I would like to direct my question to Dr. Christina, if I'm mentioning the name correctly. Yeah, so I think my question is focused on one of the levels that we have mentioned, the school and community level. So it's specifically looking at the red carpet program. So I'd like to find out how is the program being implemented, if whether it's implemented through an MOU with the Department of Education. So the reason for me bringing up this question is because I know that working with the Department of Education, it may be very challenging looking at their policies, especially when it comes to programs having to do with HIV and testing. So in South Africa, to be specific, I know there's quite a lot of pushbacks working with different schools on this. So this may not be unique only to South Africa, but also to other countries as well.
Thank you very much. We move to this side. He's already answered the question that he had. And another one?
Thank you very much. My name is Teuka Ibadza from Zimbabwe. My question is directed to Dr. Christine. She mentioned the issues of stigma-related issues in school children, especially the adolescents living with HIV in boarding schools. Yes, there is very much support when it comes to other NCDs or chronic conditions in schools. But when we are talking of HIV, it's really an issue because we are finding so many young people in boarding school defaulting their treatment, coming back on holidays with a high viral load. How best or what approach can be used to address issues of stigma in adolescents living in HIV in boarding schools? And how best can we engage the teachers and the parents with the children living with HIV to collaborate so that we won't have a high viremia in these children? What approach can be used to make this collaboration effective?
Thank you very much. That looks at the school level in terms of the ecological model. 2 gentlemen. Yeah.
So good afternoon. My name is Elizabeth Naini from Kenya. I want to direct my question to Christina on accessing and retention of HIV care for AYPs. She highlighted all the levels, which I think was a very good thing to do. But I, however, have one input that I thought it's very nice to also incorporate. In individual level, I think awareness was left out. And in Kenya, I am bringing this because in Kenya, I think we have assumed a lot that everybody at an individual level, especially the young people, are aware that they need to go for an HIV test in the facility. Recently, we had a survey, a national survey, that really took us aback, that it said that only 53% of young people are aware about or have knowledge on HIV. And so creating awareness to that individual at an individual level, so that they know that I need to go for an HIV test, is one key important aspect. Now, I know for AYPs, the most critical thing that bring about lack of adherence is transition. And transition happen in different levels. There's that AYP that is transiting from primary school to boarding school, for example, high school, boarding school. And then there's that one who has finished high school and is transiting to tertiary institution, or tertiary from, to a different, relocating to a different place of work, for example. And so that comfort is disrupted. But I am particular in the ones that are in high school. And I want to be to applaud her for bringing in the aspect of school. But how else can we strengthen and that component of transition in school, so that that young person who was adhering to medication in primary school and now at the boarding level is supported enough so that they continue with their medication the way they were. Thank you.
Thank you very much. And issues of transitioning, settling into new environments, issues of disclosure and stigma come up when they change the environment to boarding schools. That is a very good question. I think any other question before we ask the presenters to respond? I would ask her, are you able to repeat your question, the very first question you asked? They were not able to get your question. Yes.
My question was, do you come across women who withdraw GBV cases, and are they victimized? And if in that case, how do you deal with such issues?
Okay, thank you. And there are some online questions. So the first question, I think it's to Edna. Do you see women who withdraw cases of GBV? Was the question, I believe. And what happens in these cases? So I think that is a question to Edna. We'll give time to the presenters to respond. So we'll begin with Christina. Christina, are you able to respond to your questions?
I am. Thanks so much. And thanks for these really wonderful questions. I realize that a lot of the people who ask questions are kind of asking about some of the similar overlaps within some of their questions. So I'd like to try and respond to a few people at the same time. Thinking about the Red Carpet program, so it's been implemented in Kenya in boarding schools. I don't believe it's been implemented to date in South Africa, and it's very focused on building bridges, establishing MOUs, but really engaging with multiple stakeholders from education, from health, and then at individual school-based levels. So also engaging with community leaders and individual school governing boards as well, to really try and build strong bridges amongst those sectors at an early stage. And that's one of the cornerstones of that program. I think each context is different. So I can share the link to the Red Carpet program resources and toolkit online. I think they've really tried to make it, a case study in Kenya, but with the idea that this is going to be a set of tools that can be adapted and used in different settings, with the obvious need to adapt it to context and to the political and social constraints of each space. I think it's really important to remember that it's not always a smooth process and that these sectors, the Department of Education, Department of Health are not necessarily working hand in hand. I think ideally that would be what we'd be looking for to really support the health of young people in schools, but we know that's not always the case. So I think from my perspective and what I've seen of the Red Carpet Program, resources and materials, there's some really great resources and guides to try and kind of structure some of those conversations. And coming to the second question around stigma, especially in boarding school settings, I think this also reiterates the need for broader multi-stakeholder collaboration. So within Red Carpet, there's also the designation of individuals in the school settings, of teachers who are mentors and who engage with children one-on-one. And then also peer mentors who are trying to kind of do additional psychosocial support, counseling, and again, with the idea that, we're trying to kind of sustain some of the gains, really smoothing barriers to accessing ART, and then coupling these very deep dive individual responses with a much broader school-based awareness campaigns, stigma reduction campaigns around HIV. So I think there's a lot of components that this one particular set of tools is trying to tackle. And, I think, Elizabeth, you also brought up a really good point around this very foundational need to really ensure that testing and knowledge of HIV and knowledge of one's status is front and center, especially in high burden areas. So I think, there's a lot of promise in considering tools, and this is a nice set of tools that can bring together some of these different levels and different pieces in one place. I'm happy to speak more if anyone has additional questions. Thank you so much.
Thank you so much, Dr. Christina. I think we'll move on to Edna. Edna, you had that set of questions. Maybe you could respond to those questions.
Thank you. Thank you very much for the questions. But what I can see, I have only one question, which is on whether we see women who withdraw their cases. Yes, we see women who withdraw their cases, but we also offer them psychosocial support for them to be able to be confident and report. But if the GBV is of a criminal nature, like if maybe the woman has been beaten, it's physical violence and sustained injuries, the state will go ahead and prosecute, even if the woman has withdrawn the case. Because this was like a practice, women would report but withdraw. But when you then look at the reasons for withdrawal, they are deep-rooted in our culture. They are deep-rooted in poverty as well. So to avoid maybe having women dying from injuries sustained during gender-based violence, the state has resolved that they will go ahead and prosecute.
Okay, thank you. Thank you, Edna. I don't know if there was a question directed to Dr. Bilito, but you can give us a comment as we wrap up this Q&A.
Good afternoon, everyone. I don't think there was a question for me. I just want to wish everybody a very nice summit. Enjoy all the discussions that we are having there. And yeah, I'm open for, I mean, if you can visit the references that I shared on the presentation, and you are going to find some more information on community-led monitoring. So thank you.
Thank you, Dr. Bilito. And one thing about the using of the scorecard is the sustainable aspect of those scorecard. Thank you. Thank you so much for the model that you shared with us. I think moving on, we'll move to the panel discussion, and we have Grace Gina. Do I say Gina or Gina? But and then Immaculate. So to start us off, we'll start with Grace. Grace is a young person and also is a member of the YAP. And then through the presentations, we've had many barriers that are affecting adolescent and young people. So from your perspective as a young person and your experiences, please highlight to us some of the social barriers that you experience and some of the youth-driven solutions that you can share with us. Thank you.
Thank you very much. I just want to do something different. Do we have a mother with an adolescent girl here who can share? Yes, thank you. So today, young people, we are complainers. We like complaining. So as an adolescent, as a mother to an adolescent girl, I want you to be honest with us, yeah? What makes you feel shame and guilt to talk about sex with your daughter?
What a difficult question. First is our culture. It feels like it's at a taboo to talk about sexual issues with your daughter. Yeah, but now we are talking about it because when we were growing up, we used it to discuss these issues with our aunties, our grannies. But these days, yeah, you end up talking about it. But you go around the circles asking, do you have a boyfriend? And she says, mommy, you cannot talk. You can't ask me about having a boyfriend. Huh? You just know the mukwasha, I mean, the son-in-law will come when the time is right, but not now. Then I would ask, I just want to know if you are maybe having sex. Oh, mommy, no. So yes, we talk, but not in depth. And you just talk just a little, and you to maintain the relationship, you keep quiet. Yeah.
Okay, thank you very much for your honesty. And I really like her response. She was honest. But in real sense, young people, we are really having sex. Young people in the room, where are you? Are we having sex or not? Young people, we are, right? So I feel like for so many years, young people, we have been coming in the room complaining that we don't have a space to talk about sexuality issues in our community. But in actual sense, there is that space. Yeah? Oh, thank you. In actual sense, we have that space to speak about sex. But why do we come back again to talk about the challenges we are facing to access sexuality or HIV services? That's a question. So I had two questions, sorry. The first question goes to our parents. Why are you ashamed of talking about sexuality issues with our children? When we go outside, we hear a kind of a different story. That's something that I don't want as a young person. I remember at some point in time, my mom, boys are really very dangerous. They can bite or burn. I had a male friend. I tried to see if he can burn me, but no, he didn't. And that's very dangerous to our girls. Yeah. I want to go to a community as a 13-year-old girl to access service. I had sex yesterday. I go to the health facility. I met Gina. And Gina says, no, the policy says, no, you can't access PrEP. You are young. I go home. I get HIV. I get pregnant. We can see in our antenatal services, antenatal clinics, there are 13-year-old girls who are pregnant, 14-year-old. You say, have you even seen your periods yet? You'll be surprised, but that child was denied access to information. Misconceptions in our community. Even the healthcare providers are the ones in front of bringing in misconceptions about HIV, about SRHR. If you start taking emergency pills now, in the next 10 years, you will not get pregnant. You will struggle. If you start taking contraceptives now, you have A, B, C, D, E, F, G. Why are we giving our young people wrong information? Gina, I'm going to the healthcare provider now. As a healthcare provider, what determines you whether to give a young person the service that they need or not? Because this is a game whereby we should not be there to complain as young people, but we also need to hear from them. They have reasons behind them not giving us the service that we need. They have their own medical ethics. And we also have a policy maker here who even contradicts the policies. The policies say health services for all. Are you sure the services are for all? Huh? Why are you telling me that the age of consent is 16, 18, but I'm 14, I need the services. I need quality, healthy services. But when I go there, you say, no, you're too young, you don't know anything. Why are my policies denying me of going to a healthy facility to get HIV testing at 13? A policy, someone who is working in policies, they need to tell me why. Gina, this is for you.
Yeah, before we go to Gina, you have a lot to answer. And in addition to that, we know that when a young person goes to a health facility, the way they are treated determines whether they proceed to get a service or whether they go back or whether they recommend that facility to their peers. And sometimes they go to a clinic and they ask for Margaret. And when they don't find Margaret, they go home because Margaret is the friendlier health provider. So in the recent Stigma Index 2.0 report, it said 13 of the respondents faced stigma by a health provider. Then we have 34.3 feared that a health provider would treat them badly or disclose their status without their consent. Then a further 16% of the respondents had a bad experience with a health provider. I know for a very long time, health providers have been on the spot in regard to stigma, especially within the health facility environment. So Gina, are you able to respond to that? And also in terms of when a 13-year-old comes to a facility and they want contraceptives and they want a HIV test, how do you go about that? Like in Kenya, we have the age of consent for HIV testing is age of 16, and contraceptive is age of 15. Thank you.
Thank you, Grace and Maggie, for the questions. Maybe to answer your question, I should say that in my country, in Swaziland, we are Eswatini. We are lucky because when it comes to ASRH age of consent, it is 12. So we are not facing those issues. We do know that we have young mothers that get pregnant at 13. They should be able to access SRH services. It does not make sense for us to deny them the care that they deserve. And also, when a 13-year-old comes to the facility, there's no reason for me to deny them a service. But in healthcare, you should be aware, Grace. And I think this is the message that we should be giving out to the young people to say there's eligibility criteria for everything that is there in the facility. When you talk of your KBLA, your PrEP, in as much as I would love to give you the injectable PrEP, but there's an eligibility criteria. In Swaziland, it is 18. In as much as I would love to give it to you, but then there's this eligibility criteria that hinders me from offering you the service. So in order for us as healthcare workers to be blamed for not offering the service, maybe we should do the health education sessions so that young people are aware of the eligibility criteria and they are aware of where they need to knock to fix that, which is the issues of the policy. It's not with the healthcare providers, but the issue is with the policy that now puts healthcare workers in a very tricky situation whereby they see a person that needs a service, but then because of the policy, like in Kenya, they cannot give the service. And then when it comes to the issue of stigma and discrimination of young people when they come to healthcare facilities, I should say that, Maggie, we are lucky that we are trying to move from the attitudes that we have before as healthcare provider providers through the capacitation that we are getting from organizations such as your Pata Pata, your organizations such as Aspire, that has helped us to realize that we should be cautious of our unconscious biases. We shouldn't be operating from an unconscious bias to say when a young person comes, just because I am a Christian and I don't believe in a young person having sex before marriage, then I will project my belief on that AYP. And also, what I think can help with the issue of stigma and discrimination is that in our facilities as healthcare providers, let us have that safe space for young people. In my facility or in Swaziland, we call them youth-friendly corners. And we need to get that information out there to the AYPs to say, the facility has a youth-friendly corner. In that youth-friendly corner, they are capacitated about their rights as clients, which means that they have a right to access service if the eligibility criteria allows it, and they have a right to choose a healthcare provider of their choice, and they have a right to a very good experience when it comes to the facility, and they are capacitated on the services that are there, SRH services that are there in the facility. So if we can have that youth corner, we can see AYPs, and they even provide feedback about their experience when they were getting the service. So we've had that in our facility, and they were complaining about unavailability of SRH commodities in our facility. And we had to advocate to our Ministry of Health to say, can we have these SRH services so that you can give the commodities to the young people? So let us make use of those youth corners to take care of the stigma and discrimination that is there in our facilities. Thank you.
Thank you, Gina. Thank you so much. I think we have a lot to borrow for Kenya, and maybe, I think my counterparts who are in the floor from Kenya to reduce our age of consent to about 12, because we are struggling at 16 and 15. Now, moving on the age of consent, Immaculate, you work around policy analysis, and we know that we have a right to the highest attainable standard of health, including reproductive health. And yet, some of the barriers that are facing young people when they come to the health facility. So from your policy analysis and the conflict and putting the health providers in a limbo, whether to provide a service or not, what is your experience and perspectives on that?
Thank you so much, Maggie. I think in 1 second, I have seen a healthcare provider from Kenya. I want you to do me one thing. What is the age of consent for contraception in Kenya? 18 years. For HIV, 15 years. Maggie, what did you say? 16 and 15. And that's where we have a problem as a country with our healthcare workers. When I came in, I deliberately talked to our majority of our healthcare providers who are here. I just wanted to ask them, what is the age of consent for HIV/AIDS? Some were saying 14, some were saying, I don't know, 10, 15, and that's where we also have a problem. And the problem is we will fail to offer a service just because of the kind of information that we have. In Kenya, we have so many policies that talks about reproductive health, that talks about HIV and AIDS. For example, we have a document that was launched in 2022. It's called the HIV/AIDS Prevention and Treatment Guidelines. In that document, I will authoritatively tell you, if you open it, it is online. It says that any young person above 10 years old, any adolescent who has reached 10 years old, for that person to access HIV testing, there has to be a consent and an assent. Are you seeing the disparities there? We have a constitution of Kenya. We also have our HIV Control Act 2006. It clearly stipulates how our adolescents should be able to receive services from the school, in the community, in our healthcare facility. There is a gap between the facility and the school. That act clearly says that for an adolescent who is HIV positive, in school should be able to be provided an enabling environment, should be able to be provided with accurate and correct information. But as a country where we are right now, there is a limit of what information you can be able to provide to a young person in school. And you're being told the remaining information should be provided in a facility or in a community. What happens to these young people who fear going to access information in a facility? What happened to these boys who even fear going to community forums to just access information? We still have a gap. And then I think I have said this from day one in the art cafes where we are. Currently, as a country, we are in a phase in which our constitution is undergoing silent amendment or silent execution. Why? Because we are seeing some of our documents having reviews, but the community are not aware. Is it the role of the policymakers to be able to tell you, go, just go every day, every day? We have created awareness. It is now an opportunity for us as healthcare workers, as community, as young people, where amendments are taking place. They provide for us an opportunity. Our leaders have done well. And that is something I will applaud our country. You remember the presentation that was given here. We have gone to 7% reduction in terms of HIV/AIDS infection. When we were coming here, our CS made a pronouncement that in terms of HIV new infection, we are at 83%, which is a very good stride. But do we ensure that we follow the law? We have the laws very well clearly stipulated, but I think we also have gaps in terms of just ensuring that we understand our policies, we understand the legal instruments that we work around. But I would say that as a country, we are really, really trying so much. And where we feel that there are gaps, the government has also provided an opportunity for us to work together to be able to provide services to young people. Like I would still say in our school, we still have much efforts to be able to do to ensure that our young people within the schools are able to receive information, but also we have to take cognizant of the environment where we are. Yeah.
Thank you, Immaculate. Thank you. I think it's an interesting discussion because I look at it and I say, if you deny a 13-year-old a service, let's say contraceptives, tomorrow they'll come presenting pregnancy in the same health facilities that you've turned them away. Same case to PrEP and PEP. Tomorrow they'll come presenting HIV infection. So I'll open up to Q&A from the floor, and we'll have maybe a couple of questions, maximum of 6. Then please say your name, what you do and the country, and who your question is directed to. Thank you. We'll start with the lady. I think she had really struggled to put up her hand. The lady over there.
Okay, thank you very much for the presentations. I think it's not a question for me, it's a comment. Just to second Gina on the 12-year age of consent, I was part of the team that had to actually allow that to happen. There is data analysis that has to happen per country. Internalize the data. Data is showing you teenage pregnancy is starting at this age. You also do a survey of sexual debut. It is telling you the ranges where they start having sex. So the policy also has to align with that, because if you still use the statutory laws, they don't apply to the health sector. So you need to apply that analysis to the Health Act, and then you are able to make your children have access to healthcare services. It's not easy, but it's something that is practical and what is needed for you to achieve all the desired health outcomes.
Thank you. I think yesterday someone suggested as a health provider, you use wisdom. You apply wisdom, and that is a nice way. Thank you so much. The next question, I think with here at the front.
Boa tarde, sou a Maria de Fátima Vemba, sou da Angola. Eu dirijo a pergunta aí à colega, porque falou-se muito acerca dos adolescentes, quer dizer que a vossa política, testagem de jovens, 12 anos, né? De adolescentes, 12 anos em diante. Mas nós, pelo menos a nossa... Por isso é que eu digo que acho que temos que estar em conexão. Nós em Angola, pelo menos eu estou na área do SAT, eu 12 anos não vou testar uma criança, porque é uma criança indefesa e está sem o acompanhamento de um adulto. Porque eu dando um resultado, fazendo um resultado, vou fazer o pré-aconselhamento e o pós-aconselhamento. E vou testar. Testando o resultado me vem positivo. Qual é a visão que eu vou dar a este resultado? É uma criança. Por isso é que nós, a nossa política tem que ser acompanhada com adulto, que é para poder dar esse resultado, que é para podermos saber de diante em frente como é que vai ser, quais são os procedimentos. Agora, 12 anos nós testamos caso de violações, abuso sexual, ali nós vamos testar. Vamos testar e saber, e acompanhado também, porque nada nós podemos fazer de um adolescente, de uma criança de 12 anos, fazendo um teste de VH sem ser acompanhado. Porque se eu fizer isso, eu estou a violar. Então, por isso é que eu queria, porque a nossa testagem, aquilo que a colega disse, é aos 18 anos. Teste voluntário, faça o seu teste voluntariamente. Em Angola, quem procura muitos testes, que é jovens e adolescentes, são na fase de sexo masculino. Estes sim. Agora, feminina, é muito difícil. Mas eles, no caso de CPN, que é o planeamento, a CPN, que é nas consultas do pré-natal, temos muitos adolescentes, 12, 13, 14 anos grávidas. A estes têm um acompanhamento diferente. Aí sem problemas nenhum, mas também não deixa de ser acompanhado com um familiar, com um encarregado, que é para poder ser acompanhado. Então, gostaria, foi uma boa causa que ela disse, uma coisa mais, que estejamos em conexão, porque afinal de contas somos uma família, somos países africanos e que temos que seguir cada um de nós entrando em contato, em comunicação, como é que devemos trabalhar. Estamos com PATA, estamos com adolescentes, então vamos ver se o HIV terminamos em 2030. Obrigada.
Thank you so much. I think that question will be answered by Grace because she says that they have to be accompanied by an adult when they are coming for some of these services. And partly it can be answered by Gina. Any other question? Yes.
Okay, so I think from me, it's just a comment as well. I think from what Gina mentioned, I think based in Swaziland, in terms of the age of consent, is in South Africa also, if I'm not mistaken, is the age of consent for contraceptives and HIV testing is 12. But there's contradictions, you know, when you look at the policies. I think that the reason I also asked the question earlier to Dr. Christine, it was also in line with this, because when you do, you go to schools to do the testing events, to host the testing events, the Department of Education will simply not allow you, because they are not allowing or permitting anyone to test kids at schools, simply because of they consider them like not, you know, yeah, they're still minor, but the policy still gives them that right to do so. So I think that's the problem, you know, with us, like which I feel it's a barrier, you know, when you have to impart those services to young people. So that's the comment that I just wanted to simply make here.
Yeah, very true. There are limitations when you come to the education sector. You're limited on what you can provide as information and the services that you can provide in that environment. And then the other services can be provided within a healthcare facility. Another question, and then we pick the last one.
Thank you so much. Yes, we are one family, and our goal is to end AIDS by 2030, but we've got different age of consent. There's need of continuity of services. In South Africa, it's 12, in Zimbabwe, 18. So we have our children in South Africa. We have already accessed family planning methods at the age of 12. When they come to Zimbabwe, they cannot continue because the age of consent, it's 18. Even if they go to Ghana, Uganda, whatever, maybe they're going for the tertiary level. So this is some of the gaps we have concerning the age of consent. But when it comes to other conditions like testing malaria, I can send my child, go to a facility and everything is done. Then for HIV, they say they need me to consent for that. But for malaria and everything, it's fine. You see? So we are saying, where are they getting information? Then again, there's a gap at school. Like in my country, we've got the GNC teachers, guidance and counseling. They are limited than what you have said. They're supposed just to give this little information. The rest, they're supposed to get it at the facility. But they're saying at the facility, they're afraid to see that there's a mother, there's an auntie who is offering services. I want to be tested, I want to get family planning. At the end of the day, my mom will know about it. This is the issue of age of consent, which is interrupting the continuity of service.
Thank you, thank you. That's a great one. I think we'll take the last question from her. Franca?
My question goes to Grace. Grace, you mentioned something. There are spaces to talk about sex, but participants and these adolescents still come back with challenges. And now the question, how do we really identify these challenges? Because if something does not trigger it, like crying, mood swings, these participants will never talk about it or meet a counselor, and they keep on dying with these challenges. If nothing trigger it, how do we really identify the challenges?
Hey, thank you, Franca. I think I'll leave it to, we can start with Grace. Grace, you can respond to your set of questions.
Thank you very much. Thank you very much for those beautiful questions. I will begin with, I'm not really going to directly answer your question, but I will tell you a story. A 13-year-old has a boyfriend, yeah? She goes to the healthy facility for HIV testing, and they are told, you guys are not eligible for HIV testing. You should bring your parents, yeah? The mother knows this child's HIV status, that girl, that boy is HIV positive. These guys are denied service. They go and have sex. What scenario does that give you? That automatically, if our parents don't tell us about our status when we are young, if we are denied that service, automatically we are transmitting HIV at a younger age. That's the reason why continuously we will talk about HIV transmission continuing to increase amongst young people, especially the girls who are every day having sex because of so many reasons. One, peer pressure. Two, transactional sex. My parents can't afford to give me anything that I want, but my boyfriend is giving me. If I'm denied that service, how best can I protect myself or my partner? Yeah? Because the problem starts with parents. That's the reason why I asked that question. How much comfortable are we talking about sexuality issues with our children? If we tell our children the truth, it's easy for them to avoid all these things. If we are able to disclose, even if it's partial disclosure about their HIV status, it's easy for us to reach 2030. Yeah? To go to my sister's question, if you heard me correctly at first, as young people, we are complainers. My mother buys me a shoe today. I'll tell my mom, thank you for the shoe, but you didn't buy me a socks. They buy you a socks, then you say, Mom, you didn't give me soap to wash the socks. When are we addressing the root cause of young people to be complaining every day? Because young people, we come in a room, we make noise. But still, for so many years, there have been the same issues. Young people are denied service, at first, the age of consent, I think it was starting from 20 going upwards. But most of the countries we have tried to improve, going to this teenage age. We are trying to adopt it, but policymakers are adults. They're our grandmothers, our mothers there making decisions on our behalf. We are there making noise, but no change. They're trying to confuse us with contradicting policies, ABCD. But by the end of the day, there is no change. If as a young person, you're not putting in an impact in reading your policies, one, understanding the rules at the healthy facility, what service am I supposed to receive? At what age? What are the contradictions that determines me as a young person to access A, B, C, D, E, F, G? How best am I connecting with my community members, my parents? How comfortable am I to talk about real issues with my parent? Because I believe in having a very good discussion with my parent than my peer. I will tell you that, you know what, Immaculate, sex with a condom is boring. Try it without a condom. Have I helped Immaculate as a young person? No, that's exactly what we are doing as young people. We give our peers false information. As young people, I also encourage them to look for youth corners, safe spaces that are available at rural at our healthy facilities. But if we go to a typical village, you will not find these services. And all these challenges we are talking about, they are the ones suffering. It's not me in an urban community. I have sex today. I know where I can get PrEP. I know where I can get the emergency pills. But someone in the rural community in Kasumu, are there these services? No. I go to a healthy facility. I'm looking for a pregnancy emergency pill. And Gina tells me that we don't have it. What does that tell me? Whatever we discuss in the community, it's not the exact service I will find at the healthy facility. How best can we as young people work with the healthy facility, with our communities to ensure that the services that we talk about are the exact services that are available at the healthy facility, are also the exact services that our community leaders, our parents are aware of. Because it won't make sense for my mom to see me with a depot here. She'll ask me questions, which I will fail to answer as a young person. And I will not respond to her. Thank you.
Thank you, Grace. I think these are the realities on the ground. Yeah, and as programmers, we have to respond to those realities. And that's why young people are giving out their voices. What are the barriers they are facing and they continue to face regardless of the policies that we have. And a lot of advocacy is required in terms of advocating for better policies. Immaculate, you can go and respond to your questions.
I think with the discussion and the comment that we received from our colleague from behind, yes, I would agree that it is a time that we need to really understand the people we are dealing with. The reason why I think I agree with her is because look at the age that our young people are having sex. It's too early. I was privileged to implement a project. My first project that I did after my graduation was an evidence-based intervention. And we were dealing with young people in primary schools. And we were trying to teach them, to give them information about sex, sexuality, and all that. And I happened to be in a classroom of 8, 9 years. And there were these strong boys, 8 years, very strong 8-year boys. We call them mature minors. I don't know if they are mature minors, 8 years. And that is a statement that I will never forget up to today. Because when I look at my 10-year boy and I compare with the 8-year boy that I saw in a certain village in my country, her sentiments ring in my mind up to today. That young boy told me, Madam, as much as you're teaching me about this, and this, I will tell you that sex is sweet and we have to do it. That is a young boy telling me that in my face, because we had created that enabling environment that you can be able to tell me what is your problem. And they were open, madam, sex is sweet. And they're putting it in their local language. So you imagine how it is coming through. And so I am saying, whenever I meet with policymakers who keep on denying that this is not the situation, I feel so sad. And what I would also want to say is, I think it has reached a point. I don't know who bewitched us. I don't know if it is bewitching or we just have a problem. I feel we have so many policies as Africans. If somebody, with no offense, if somebody opens our Ministry of Health portal and you just go to the section of resources, look at the number of policies, guidelines, and frameworks that we have. Let's just pick reproductive health. We have issues on youth-friendly service. We have issues on reproductive health as a standalone. We have reproductive health in emergency situation in COVID. We have issues of family planning. We have issues of, there's so many. I am a person who deals with policy, so I take a keen interest in going into all those pages. It is good, but are we able to internalize all those documents that we have as individuals? Today, you give her as a healthcare worker a sexual reproductive health policy. Tomorrow, you're saying we are launching an Health Act. Tomorrow, we are launching HIV Prevention and Control Act. Tomorrow, we are launching HTS operational guidelines. Tomorrow, we are launching reproductive health in emergency situations. She will get lost at the end of the day. We wouldn't understand what is the framework that we have as a country. And I would also want to repeat that it is also a time for us to be able to understand spaces where we work. I work around policies. I cannot be able to shout around issues of policies as an individual. I need evidence. I need support. But most often, what happens with our healthcare providers? We fear. It's not bad to fear. In my country, if you are a health provider, in a certain county where I work, if you're a health provider and you come up openly talking about the challenges in your health facility, the next thing you will see, you will be taken to another island and somebody will be brought here. So those are the challenges that we are experiencing, even as we are trying to advocate for harmonization of some of these instruments, strategies, and frameworks that we have. It is a long stride that we have to take, but I don't know. Also currently as a country, there are bills that have been introduced. We have a bill currently on family that is trying to say reproductive health matters should be left to the family. It is trying to say, I've read it, it is trying to say that why are we giving our young people sexuality education? We are teaching them how to access, to do sex. We are teaching them issues of LGBT community. We are teaching them on issues of just having sex. But we are saying that is not what we want. So if that bill goes through, I think we will be still going downwards. Our religious leaders have tabled a bill in the parliament. Still, it's a challenge for us. We have made strides, but if we are not careful as a country, we will be able to go down. I wish I would be able to share with you some of the different as a country, how our legal environment is really from 2025. It's really going to take a shift, and people are not aware on the kind of shift that it's going to take. But we have made strides. But if we are not careful with the amendments that are happening silently, I often tell my colleagues that we work with that I am seeing a situation where now the opposition is going to enjoy as compared to the strides that we've made as some of us who advocate. Yes, indeed, as a country, Maggie, we still have those challenges and gaps in terms of our policy. They are too much. National government is making, the county is making. And I don't know who gave our counties the mandate to make policies, but they continue making policies. So many of them. So you have to deal with the national, and the national says domesticate ours. Yes. Instead of domesticating at the county level, we are again making ours. That is the challenge.
Thank you, thank you, thank you. I think a lot of issues on policy. We can stay here the whole day and the whole week. I think it's the same scenarios across different countries. Gina, I know you have a lot on your plate as a frontline health worker. So maybe you can wrap up this session with your remarks.
Thanks, Maggie. I think as healthcare workers, we are at the center of everything. And to end stigma and discrimination in our facilities, we need to know that it's not only about our facilities, but we need to bring in the youth. We need to know what they want, which means that nothing for them without them. We need to engage them. We need to raise awareness about our services to them. And we also need to be informed by them how we need to offer the services to them, instead of us telling them how we want to offer the services. And then we need to be flexible enough to change our patient flow and also to change the way we offer the services to them. And also not just, I think Grace did mention earlier on to say, even if she does come and get your implant, but if she comes with an implant in her arm, she's going to have a problem at home because where did you get this? So we need to also go an extra mile and raise awareness in our caregivers and our parents. I think I've done this in my facilities. I've had a meeting with the caregivers to say, why are we having issues with SRH, with our adolescent accessing SRH? And you'll be surprised because parents are afraid to talk about SRH with their children. And I advise them how they can talk to them. I did a demonstration of how I talk to their kids when they come to access your emergency contraception pills. I let them tell me everything. They'll tell you I have 5 boyfriends. I say, is it? I only have 1. How did you manage to have 5? So I'm not encouraging her to have 5 boyfriends, but I want to get all this information. You'll be surprised that they'll tell you that my other boyfriend is 35 years old. If I had said, why do you have 5 boyfriends? Would this adolescent have told me about the 35-year-old boyfriend? They wouldn't have. So we need to know and be wise on how to engage young people so that we can get the information from them. When I have all this information, I'll be able to advise them so that they can make informed decisions. But what we are doing now as healthcare providers and also as parents is that we cut them short with the reaction we have when they tell us. We need to keep quiet, let them tell us everything, and then we advise them so that they can make informed decision. You will talk about abstinence with a person, you should be talking about PrEP and also FP because you did not allow them to tell you everything. And then also we need to lobby in our gatekeepers, that is the influential people in the community, the people that are going to help us to desensitize or rather to get rid of stigma and discrimination in our communities. Your pastors, your traditional healers, your teachers, your head teachers, your traditional leaders, all these people need to be sensitized to make sure that everyone is in the same page, and then they allow you to nurture a very good environment for our AYPs and also for people that live with HIV in general. Thank you.
Wow. Thank you so much for the well articulated discussions and information. We really appreciate. We have learned a lot. So let's use this information to break all those barriers. Policy level, individual level, facility level, health facility level, we can do something so that we retain our adolescent and young people on treatment, especially on the holistic care. So as we conclude, we want to appreciate you. Thank you for actively participating in these discussions. Thank you for your comments, your compliments of the information that we got from our various speakers. And we want also to appreciate our presenters online. They've been waiting patiently joining us online since Monday. We really appreciate, and now they are still online. Thank you, Dr. Christina. Thank you, Edna. Thank you, Dr. Apilito. We really appreciate, and everyone joining us online, we appreciate your time, and we appreciate that you participated in this session. And thank you to our panelists. As we have said, that the information they've given us is very valuable. Then thanks to our interpreters. We want to appreciate and thank you. Yeah, we've been able to capture everything that has been said here through your assistance. We appreciate that. Everyone, thank you so much. My co-chair, thank you for facilitating your session. As we close, we have one announcement. Please check that there's an information desk outside. We are requested to check our departure time. So we know that others will be leaving today and others tomorrow. Please check your departure time. And then also one last one, we are reminded, all the MOH officers were reminded to join the session at 2, same place, the executive board that side. Yeah, past the marketplace, then that board, that boardroom that side. Okay, thank you so much. This session has come to an end. We appreciate. Thank you.